Hey, everybody, it's Doug Green, and I'm the publisher of Technology Reseller News. And I'm very pleased to introduce John Bright, who's the CEO of Med Claims Compliance Corporation. John, thank you for joining me today.
I'm glad glad to be here, Doug.
Well, I'm really excited about this podcast because not only are we going to be discussing two huge topics, healthcare and AI, but I think we're going to be introducing to everybody some ideas they haven't heard before. And I think a lot of ideas that people need to hear as they think about this market, enter this market, or maybe you're already in this market as a user. Whichever way it goes, I think everyone should hang out and take a listen to this today. So before we dive into all that, John, what is Med Claims Compliance Corporation?
So we're a technology-enabled service. I have a background in development of electronic medical record software from back in the early 2000s, 2001. And I developed this set of tools to relieve clinicians from the burden of data entry at the point of care, hospitals, outpatient clinics, so on. And that's what we do. We call it a technology-enabled service because we're actually providing a service with the technology. It's a SaaS model. And the service is that we can generate correct, compliant medical records at the point of care for a doctor that is using his voice or her voice in an ambient multi-speaker scenario with a patient. And then we can code it correctly according to federal guidelines in the U.S. or the national health system in the U.K. or Canada. And then we can compliance check it according to the program integrity compliance guidelines that health payer, government payer, private payer has. And then we can produce it to the end user clinician and tell them, here's how you bill your claim correctly. Here's how you're in the lanes or outside of them after we've told you what the coding is that you should use in your billing forms. And that's the service we provide. We just use pure technology about 90% to do that successfully and accurately. That's what we do.
Now, when we were discussing our podcast today, the biggest takeaway I got was this, that not only do you feel, I think, that AI is needed to revolutionize and change the accuracy and efficiency processing of medical claims, but there's still a need for a human component.
Yeah, it's true. I've always believed that. As much as I think we would all like to see full automation, it's just not possible. And it doesn't matter where you try to use artificial intelligence or machine learning. The bottom line is that a machine doesn't have a spirit. And without that spirit, it lacks a moral compass. And just because it can do certain things, it does not understand that there's certain things it should not do or say or insert or opine about or anything else. And that's where full autonomy starts causing problems. So we use a human in the loop machine learning model at our company. And we have coding professional certified personnel as the humans in the loop that deal with the anomalies the algorithm will try to produce on its own. And before we deliver the end product to our clients, which is a fully compliant medical record with the payer that they are contracted with, like Medicare in the United States, coded correctly. The coding is checked against the diagnostic codes and the treatment codes to be appropriate. Cross-code referencing is what that's called. And then it is compliance checked with a rules engine at the very end for things like coverage determinations and medical necessity. But every once in a while, as long as we've been training this algorithm up, which is about 13 years now, It will make a mistake or get something wrong or say something it shouldn't say or insert something it shouldn't. And we've created a script in our product that is able to analyze the final content and tag what we call an anomaly, something that doesn't fit, and produce it to a human in the loop on the back end on a dashboard that I designed for the human to use to manage it. So, like for instance, if a doctor is telling you in an ENT exam that your lymph nodes feel swollen on a throat exam, but his accent or dialect, sounds like, Doug, your lymph nodes are pretty swollen. Okay. Well, the speech recognition engine in all of these tools can understand that as LIMP because of how I said it. So the speech rec thought it got it right, kind of like, using Google Voice on your phone or some other speech rec engine, but it's wrong. But what makes it wrong is not the spelling. What makes it wrong is the context around it. So it correctly transcribes that I'm talking to you and doing a throat exam, and let me feel your throat. Okay, that's before the anomaly occurs. And does it hurt when I press on the left side, Doug? Does it hurt when I press on the right? Yeah, a little bit. That's your response. See, so all of that happens before the anomaly occurs. So when I say as a physician, yeah, your lymph nodes feel a little swollen on both sides. Well, LIMP doesn't fit with any of that content. So we've created an algorithm that analyzes the final output, relevancy tags that and says, this does not belong here, and presents it to a human because it's not allowed to delete anything or remove it by itself. It cannot operate autonomously. I don't let it do that. Okay. So not only that, but when the dashboard that the human is using gets the anomaly presented as what's called an exception. So I've got an exception on this patient encounter that for one of our clients. Then when they open it, the anomaly is tagged and highlighted. And then up in the top of the screen in the dashboard is the audio player. And it's queued up exactly to where that occurred in the audio recording itself. So it'll queue it right up for the auditor at 4 minutes and 31 seconds into the encounter, just in case they want to listen to it. And then the auditor can put the headphones on. Let me just make sure, I understand what this doctor just said, and then make the correction. In that context, on the machine learning and deep learning side, if the same anomaly in the same context occurs multiple times, after about 4 or 5 corrections, it won't make that mistake again in a throat exam with an ENT clinic. So that's where we've trained it. And now we've got one less anomaly to deal with. And that's why we use the humans in the loop. And our clients never get anything that's wrong or, in error or is not usable. We make sure they don't.
So you've actually used machine learning to tell the humans where they need to do the oversight.
Oh, yeah. Yeah. Because we don't want them spending any time on it at all.
Right.
This is a 5-second, 6-second correction I was just describing.
But critical, right? It's a small thing for a person, but it could be a big deal for the patient.
Yeah. Some of our, you just made me think of this. Some of our so-called competitors, they know what I'm talking about, and they are public about the fact that, we use a human in the loop too, but we call it the clinician in the loop. And they literally put that in print. And that's an acknowledgement that that's the best model. But in my mind, as many times in motion studies with doctors and patients at the point of care I've done and videotaped over the years, I do not want my client physicians to be that human. They've got better things to do, like being a doctor. So I took care of it for them.
So, why do documentation challenges and billing errors persist despite advances in healthcare technology?
Well, I just gave you one example. So our competitors make the clinician the human in the loop. So if you're using one of those tools and you know what I just explained is true, you have to read everything it just generated before you can use it to make the corrections yourself. So now you're being slowed down again. You picked up a couple of minutes because 80%, 85% of your medical record has been generated for you, but is it accurate? Is it in the proper format? Is
Right.
this how I would say this? Okay. So now we got to stop and read. And if it was a 20-minute patient encounter, they'll go out in the hallway and leave the patient sitting there, and I've got video of them doing it, and they'll look on their phone or whatever terminal they're at, and okay, let me read this now and make the corrections I need to make so I can see if I can use it or not. The problem is they've got 4 or 5 patients waiting in other exam rooms down the hall for them to get in there. So in our case, we never wanted that to happen. So we made all those fixes for them. What they had to do was become confident in the output, which they do very quickly in our case. They'll read them until they realize, you know what, I don't have to read these anymore, so I'm not going to. Now they're
John,
moving faster.
John, we actually have the phenomenon now, you've read about it, of clinicians, physicians just simply dropping out of the entire insurance model.
Mm-hmm.
They're just, pay me a certain fee every month, Mr.
Yeah,
Patient. And,
yeah.
So we see this so-called provider burnout caused maybe by excessive documentation demands. We hear about it, and people are writing about it. Is it your feeling that what you're inventing here with AI-driven tools may curb that problem?
Oh, it absolutely does. Jamie, my team and I'm in Los Angeles at Cedars-Sinai Medical Center right now, and one of the very first doctors I ever had on this platform, we were meeting with last night, and he was able, and he could tell you, and I'm happy to have him on the show at some point if you ever want to do that, but he went 30, 40 patients a day in a 6-hour shift and never touched the keyboard once. He just walked around with my iPad in his hands and went in one exam room and out the other with a quick look at the medical record for the patient on a terminal at the nurse's station before he walked in the room. And he just kept going all day long. I followed him with a camera and videotaped him, and then at the end of that day, I watched him sit at his EMR terminal and sign 32 patient records and close them to be billed the following morning. Click, sign, click, sign, click, sign, click, sign, click, sign, click, sign. And I even asked him, I said, Dr. Sadi, don't you want to look at any of those? And he turned, I was standing behind him, and he turned over his right shoulder and looked back at me and goes, nah, John, you guys got this. I'm not worried about it. There you go.
Do you feel that in a way you were restoring his joy of actually just being a doctor?
Oh, yeah. I mean, they I would take other new clients. I would bring them. I started this here at Cedars 13 years ago. The doctors here were my guinea pigs. They helped me develop this. And I would bring new clients here for references on large accounts. And I never had to ask them or, talk. I had to ask them if I could come to their clinics, of course, And they would usually take those visits at lunchtime when they didn't have a lobby full of patients. And the things that they would say in those reference meetings were astonishing to me. They became very astonishing. They didn't talk about what I thought they would talk about, like how easy it is to use and, so on. They started off with what it did for them personally, just shocking. And they would say things like, I see my last patient, I turn the iPad off, I put it down and I leave and I go home and I'm done for the day. I have no more work to do tonight. I don't have to chart. I don't have to code. I get to have dinner with my wife and my children. I'm much more relaxed. I mean, they would just go on, and that's what they led with, what it did for them personally. And then later, the stuff that I thought they would talk about first was increased patient access, how their patient scores had gone way up because they were face-to-face interacting with them, and how they were making more money because they were seeing more patients with a load that they could handle as a physician that they were comfortable with, because I gave them the ability to manage their own time however they wanted to.
Right.
And all they were doing was being a doctor. They weren't being overpaid data entry people that needed to also be coding and compliance experts, because I was taking care of all that stuff for them.
So you're in a way, it's funny that we're talking about this. This is everyone's talking about the delivery of the promise of AI. This is actually happening here.
Oh yeah, I've been doing it for a long time. Yeah. It does something else too that you just made me think of. It, you know, participating in the United States in coding and claims preparing a CMS 1500 to be sent to Medicare. Okay. I'm a third party. I'm a HIPAA compliant under contract third party, like a revenue cycle management company that's billing for a doctor. I'm no different in that context. However, I'm up at the point of care. When I say me, my technology, right? I capture that encounter. I have a historical archive of those audio files, and they can help protect physicians, if needed, against false claims, malpractice, because they can be recalled. The doctor's attorney can ask me, can we have a copy of that audio file? And then I'll decrypt it from our primary recording format and turn it into an MP4, put it on a stick, and securely transfer it to the client upon their request. And they've found that to be very useful. It reduces their premiums, I'm being told, which is great. But also, when the payers, and they know, in the United States, the insurance companies know about me, about this technology. They know that it's capable of submitting a claim cleanly to them. And it is. And one of the reasons why is because, I have the output set up in such a way that clients that, we choose our clients very carefully in the United States in the commercial fee-for-service space. And we want to make sure that, everybody that understands, we want to make sure everybody understands what it is that's unique about us versus everybody else. We generate compliant, correct, 100% of the time, medical records, coding, and compliance check. We generate that data. Now, whether I drop it in your billing software and you press the button to send it to the payer yourself, or if I send it for you, it's still the same. It's still the same. So that's the other benefit. So it helps with things like surprise billing, with patients that have out-of-pocket expenses, because it correctly generates the reimbursement for the encounter according to the contract the provider has with Medicare, for instance. And it also prevents Medicare from getting a claim they have to, analyze, review, pre-pay review, post-pay review, hold up for a while, deny on coding and so on. That doesn't happen in our world. So,
John, I really want to thank you for joining me today. This has been really interesting. We could go on and on. I'm looking forward to our next podcast where maybe we will actually be able to see this in operation. This
absolutely.
sounds very promising, and it's interesting that it's already happening. Where can we learn more?
So our website is medclaimscompliance.us. And we have 6 different products that you can see there that all are built from a single algorithm that have some variation of what I've been talking about. Happy to come back and show it to you more in some capacity. Thanks for the invite.
Well, John, thank you. Thank you for literally the most timely podcast of them all this week and all the months, I'm sure. Looking forward to the next time, but thank you very much.
Great. Thanks very much, Doc. Talk to you soon.